I think it's 3 o'clock, so we'll begin now. Is that okay?
Yeah, sure. I'm good.
Yep, sure. Okay. Okay, a very good evening to everyone in attendance. Welcome to the College of Physicians Malaysia webinar, organized by the College of Physicians Malaysia. So this week, we will kickstart the month of endocrinology, and the topic for today would be the approach to an incidental adrenal mass. So we are very privileged to have esteemed panelists with us today. We have our chairperson, Professor Dr. Norella Sukur, and our speaker, Dr. Siti Sana binti Wan Azman from Hospital Sultanah Nur Zahira, Terengganu. So before we proceed further, let me just give a brief introduction about our chairperson today. She's Professor Dr. Norella Sukur. She is a professor of medicine and senior consultant endocrinologist at the Department of Medicine at University Kebangsaan Malaysia Medical Center. Prof. Dr. Norella obtained her medical degree from USM and then further obtained her Masters of Internal Medicine from University Kebangsaan Malaysia. She then proceeded to further her studies and obtained her Doctor of Philosophy from the University of Brisbane, Australia in 2009. Prof. Dr. Norella has won many awards. To name a few, one of it is the University of Queensland Dean's Award 2009 for Outstanding Research in Higher Degree Theses. And she also got a Postgraduate Student Academic Excellence Award by the Malaysian Student Council of Australia. She is also the Fellow of the American College of Endocrinology, making her the first Malaysian woman to receive this recognition. Prof. Dr. Norella has been actively involved in our Malaysian CPGs and also has published many studies in high-impact journals, for example, the New England Journal of Medicine and the Lancet. So I think she is very familiar to the endocrine fraternity, and without further ado, Prof. Dr. Norella, the floor is yours.
Thank you. Assalamualaikum and good afternoon. Thank you, Dr. Vidya, for the kind introduction. I would like to thank the College of Physicians as well as the Hospital Typing Medical Department for organizing and dedicating the month of August for endocrine topics. Now, it gives me great pleasure to chair the first series of endocrine webinars. We have many fascinating topics lined up for you, and today we will delve into a topic that may not be so straightforward and may be challenging to some of us. Now, with this, I would like to introduce our speaker, Dr. Siti Sana Wan Azman. Now, Dr. Siti Sana graduated from UNIMAS Sarawak in 2005. She subsequently obtained her MRCP UK in 2015 and completed her endocrine fellowship training in 2022. Now, I had the pleasure of working with Dr. Sana when she did her training with us, and I can attest to her dedication, her hard work, and she's very reliable and pleasant to work with. Now, she's currently an endocrinologist at the Hospital Sultanah Nur Zahira, Kuala Terengganu. Now, today she will kickstart the endocrine webinar with a presentation on approach to an incidental adrenal mass. Now, if any of you have any questions, feel free to type your questions in the chat box. Dr. Sana will address your questions at the end of the presentation. Now, with this, I welcome Dr. Siti Sana. Sana, the platform is yours. Thank you.
Thank you. Thank you very much, Prof. Ella, for the very kind introduction. So I will share my slides now. Can you see my slides?
Yes, we can.
All right. Okay, sure. So today, thank you, College Physician of Malaysia, for inviting me to give this topic today. So I'm going to deliver a topic entitled Approach to Adrenal Mass. Okay, so my talk today will mainly based on the latest guideline on Endocrine Society of Endocrinology, CPG, on the management of adrenal incidentaloma, which was just published last year in 2023. So this is still very new, and hopefully I can summarize this very well during today's talk. Okay, this will be the outline of my presentation. I will be going through some introduction and case, the imaging phenotype in adrenal mass, functionality testing, when do we consider the role for adrenal biopsy, surgical management and follow-up, and a special topic on covering on adrenal incidentaloma in young patients. As an introduction, most of adrenal masses, they are discovered incidentally, what we call adrenal incidentaloma. And to define an incidentaloma is actually when the adrenal mass is detected on imaging, not performed for any suspected adrenal disease. And usually the size is more than 1 centimeter, unless if there is any clinical signs and symptoms to suggest excessive hormone secretion from the adrenal gland. So the prevalence of adrenal incidentaloma, it depends and varies according to different studies. So one autopsy study actually reported a prevalence of about 2%. And if compared from 1995 to 2017, the prevalence has increased tenfold, mainly due to representing adrenal incidentaloma due to growing number of cross-sectional abdominal imaging that were ordered in the population. So adrenal mass, we will not just see during the abdominal CT, but we may be able to see during the lung CT as well. So there are now growing numbers of referrals for adrenal incidentaloma to our endocrinology clinic as well. So another study from radiological studies actually report the prevalence of adrenal incidentaloma around 3% in adult more than 50-year-old and about 10% in adult more than 18 years old. And another study, if you can see from this graph, if they are actually 20 years old and younger, the prevalence is very low, only less than 0.2%. And as they reach later age, more than 70 years old, the prevalence can be as high as 10%. So just to deduce here, basically the prevalence of adrenal incidentaloma will increase with age. And what are the etiology or the differentials that we have to think about when we see an adrenal tumors? So basically the commonest cause of adrenal incidentaloma are adrenal cortical adenoma or macronodular bilateral adrenal hyperplasia, up to 85% of cases, whereby majority of them, 70%, are non-functioning, up to 50% can be mild autonomous cortical secretion, which I will discuss it separately later, followed by primary hyperaldosteronism and overt Cushing's. It may be due to benign mass such as myelolipoma, about 3%, pheochromocytoma, 1 to 5%, ACC, adrenal cortical carcinoma, about 0.4 to 4%, and other metastatic adrenal mets, which is about 7%. So adrenal mass, it can be bilateral as well in about 10 to 15% of cases. And when we encounter bilateral adrenal mass, we might have to think separately what are the differentials in a patient with bilateral adrenal masses. So basically, we have to think about whether these are metastatic from any underlying primary malignancy, whether this is lymphoma, congenital adrenal hyperplasia because of the hyperstimulation from excess elevated ACTH level, bilateral cortical adenoma, whether this is infiltrative or infectious, such as in histoplasmosis, hemorrhage into the bilateral adrenal gland, or bilateral pheochromocytoma, especially in familial pheo, if we're talking about pheo in the set of Mann-2 syndrome or VHL, or in a neurofibromatosis patient. So all these familial PBGL, they may come in with bilateral adrenal masses, which might be due to bilateral adrenal pheo. So if you can see here, okay, the first photo actually showed a bilateral adrenal mass due to thymic carcinoid from hyperstimulation of ectopic ACTH. Okay, and this is a bilateral adrenal hemorrhage. And this is a bilateral adrenal mass, which actually was an adrenal lymphoma. So we always talk about functionality testing in a patient with adrenal incidentaloma or adrenal BAS, but when we are dealing with bilateral adrenal masses, we have to think about the possibility of adrenal insufficiency as well. So we might need to assess a residual adrenal function with a synectin test. So I will start off with my case presentation and we'll go along based on this case later. Okay, this patient that I encountered end of 2022 is a 48-year-old lady. She was diagnosed with right breast carcinoma back in 2018, and she underwent right mastectomy and axillary clearance in late 2018 and completed the fluorouracil, cyclophosphamide cycles chemotherapy and 15 cycles of radiotherapy in February 2022 and was put an anastrozole as a hormonal treatment. So the surgical team actually did a CT surveillance for 3 consecutive years from 2018 and 2020, which showed no local recurrence or metastasis. And they also did a bone scan which showed no bone metastasis. So during this time, she was staged as stage 2 breast cancer. Unfortunately, in June 2022, they did a CT surveillance, showed a lesion at the left adrenal gland, which gives rise to a possibility of metastasis with a maximum diameter of 5.6 centimeter. The FDG PET scan during this time showed avidity at the left adrenal mass, which was concordant with the finding of the CT scan. So at this point, the patient was referred to us end of 2022. And how will we have approached this patient then? So from here, when we have adrenal mass, first we have to talk about whether there is any signs and symptom to suggest any hormonal hyperfunction. Okay, we have to look at the imaging characteristic of the adrenal mass, and we have to do the hormonal functionality testing. Okay, when we talk about symptoms and signs of hormonal hyperfunction, we do want to ask them about any symptoms of pheochromocytoma, such as paroxysm, the classical triad of headache, sweating, palpitation, any symptomology of Cushing, such as excess weight gain, any recent history of fractures, any easy bruising or thin skin. And we want to ask them regarding any history of hypertension or hypokalemia to suggest primary hyperaldosteronism, any hirsutism, any excessive hair to suggest androgen secreting tumor. Okay, back to our case first. This patient basically denies any paroxysms of headache, palpitation or sweating. She denied any rapid weight gain, no easy bruising, no purpose striae, and no symptomatology to suggest any androgen excess. She remained normosensitive and normocalamic, and she was lean with weight of 54 kilo. And somehow CT adrenal was already ordered by the surgical team on the 27th of November, which showed a large irregular lobulated solid mass which arises from left adrenal gland, currently now already measuring 7.3 centimeter in the maximum diameter. So if you can remember, the mass was previously 5.6 centimeter, and within a span of 5 months, it's already increased to 2 centimeter in the maximum diameter. And this mass was homogeneously enhanced. Okay, you can see the plain CT here, and this is the enhanced CT. And you can see that it's a very heterogeneous. There is a hypodensity area at the central area, which indicate a central necrotic activity there. And the HU is high, 30 to 40, and absolute washout is 45%. So what does this CT information tells us? All right, so when you talk about adrenal imaging, CT adrenal is always the first line, whereby we want to see the Hounsfield unit from the non-contrast CT. And this is currently the most reliable imaging tool to assess adrenal mass. This is followed by MRI in selected cases, whereby MRI has a superiority where it uses a non-ionizing radiation-based imaging modality, and they use the principle of CSI, what they call a chemical shift imaging. And another imaging is FDG PET, mainly we use in the setup of underlying malignant disease. So what do we want to see from our CT adrenal report, and when we want to see the CT adrenal image, and what we want to actually ask our radiologists are actually the phenotype of the imaging, which is actually very important. So what do you want to determine is actually you want to see whether this is actually lipid rich or lipid poor. When we talk about lipid rich, is when the pre-contrast Hounsfield unit is less than 10, absolute washout is more than 60%, relative washout more than 40%, and lipid rich basically usually indicate benign adenoma. And when we talk about lipid poor, it's usually when pre-contrast is more than 10 Hounsfield unit, but recently more and more literature suggests to increase this Hounsfield unit to 20, and absolute washout less than 60%, relative washout less than 40%, and lipid poor usually indicate either pheochromocytoma, adrenocortical cell carcinoma, or metastasis. And when we see a CT adrenal with a size of 4 centimeter or more, it increases the risk for hormone secretion and cancer. And this is the formula how the radiologist will calculate the contrast washout, which I will not go into detail, but basically they will have a formula whereby they will see the Hounsfield unit on different stages of CT adrenal protocol, whereby they look at the plane, they look at the portovenous phase, and they look at the delayed phase. Okay, and the principle of doing a contrast enhanced CT, whereby your benign adenoma, you usually will take up IVCT contrast very rapidly, but also they also have a rapid loss of contrast, what we call a contrast enhancement washout. However, malignant adrenal lesion, usually it also enhances rapidly, but it shows a slower washout of the contrast medium. Okay, so I will just go through briefly. Okay, if you can see here, this is the lipid-rich benign adenoma. Usually they are less than 4 centimeter, and you can see here the margin is very well defined. And on the enhanced CT, it's homogeneous, all right? And the HU here is documented to be 5 HU, which is less than 10. And when we talk about pheochromocytoma, usually they are very dense, you can see here, and very vascular. And you can see that usually it will enhance on the CT, all right? And the HU value on plain CT, unenhanced CT usually shows a HU value of more than 20. And this is another serial imaging of pheochromocytoma. Okay, you can see it's very heterogeneous, okay, it's very well enhanced, and it's very vascular. In adrenocortical cell carcinoma, usually they are very large. One study reported a mean size of ACC in their cohort to be about 10 centimeter. Okay, and you can see here, after post-contrast, it's very inhomogeneous density due to tumor necrosis and hemorrhage. And you can see that the attenuation is heterogeneous. Up to 30% from the CT adrenal imaging, you can see calcification. And you can see that this margin is very irregular. And ACC, you might be able to see there's some adjacent evasion as well from the primary ACC. And in adrenal metastasis, you can see here from, you don't really see the heterogeneous, inhomogeneous consistency, but basically when you do an enhanced CT, you can see that it's very inhomogeneous and very irregular. And if you're talking about adrenal metastasis, it tends to be bilateral as well, right? So the primary malignancy that can metastasize to the adrenal, such as the lung malignancy, breast, colon, kidney, and melanoma. And up to 75% of patients with adrenal mass represent metastasis in patients with known cancer. So I mentioned just now, the etiology of adrenal mass or adrenal incidentaloma is about 7% might be due to malignancy. But when you talk about a patient with known to have a primary malignancy, up to 70% of these patients with adrenal mass are most likely due to metastasis. All right, so I mentioned about chemical shift imaging, CSI. So basically, this is actually uses a different sequence. You have an in-phase and out-of-phase. And when you talk about lipid-rich benign adenoma, okay, usually when you do the MRI, this is the in-phase MRI, and this is the out-of-phase MRI. And the out-of-phase MRI usually will show a signal drop, okay? And you can see there is a hypo-intensity compared to the in-phase MRI, whereby it is almost iso-intense to the liver, all right? So this basically indicate lipid-rich, but when you're dealing with pheochromocytoma or ACC, usually they do not demonstrate this signal drop when you do the out-of-phase imaging from the MRI adrenal. Okay, so for FDG PET, they use a principle whereby the cancer cells have an increased requirement for glucose. So therefore, when you do a FDG, this might light up and might be avid. But bearing in mind, this might not be so specific because some in instances whereby sepsis, infection, they can have high glucose metabolism as well. So if you PET the FDG imaging together with PET with CT scan, so this basically will be more specific and sensitive because CT scan has a better spatial resolution. All right, so when you pair this together, it can potentially discriminate between benign and malignant adrenal lesion. Okay, and if you suspect ACC or pheo, you can identify mets together with this. And if you suspect adrenal mets, you might be able to detect where is the primary tumor as well. Okay, let's go to the functionality hormonal testing. Okay, first, we want to rule out whether this adrenal mass is actually adrenal Cushing's. So you want to order 1 milligram dexamethasone suppression test, whereby usually we will give dexamethasone 1 milligram at 11 p.m. and sample the early morning cortisol at about 8 o'clock in the morning. And the normal result that we expect this to be is less than 50 nanomole per liter for it to be appropriately suppressed. But you have to bear in mind, when you interpret the ODST result, you have to see whether the patient is on any medication that might affect your ODST results, such as phenytoin, your metabolizers, such as your rifampicin, okay, your carbamazepine, etc. And also you have to see whether the patient has poor absorption or not. Okay, so plasma-free metanephrine is for you to exclude pheochromocytoma. If the patient is hypertensive with a HU, if the patient is hypertensive with or without hypokalemia, you do want to order your aldosterone-renin ratio for ARR. And in selected cases, especially if you suspect ACC, because 30% of adrenal cortical cell carcinoma might be functional. And we do know if they are actually functional, they have a poorer prognosis compared to the non-functional ACC. So you might want to do your sex hormones such as your DHEAS, meaning the dihydroepiandrosterone, which is your androgen which rises from your adrenal, okay, and other like testosterone or estradiol in male as well, or androstenedione, but this is not widely available in Malaysia. And if we're dealing with bilateral adrenal masses and you are thinking about whether this is congenital adrenal hyperplasia or not, then you might want to do a 17-hydroxy progesterone. So the guideline basically says any HU more than 10, you should be sending plasma-free metanephrine or 24-hour urine metanephrine. Okay, so let's just discuss briefly on mild autonomous cortisol secretion. So basically the latest guidelines say that we should move away from the terminology of subclinical Cushing. And when we define, how we define max is actually patient without any signs and symptoms of overt Cushing syndrome, whereby the post-overnight dexamethasone suppression test cortisol is above 50. So you want to consider this to be max. Right. So basically, the old guideline actually mentioned that if you have an ODST less than 50, then this is normal, appropriate response. If you have 50 to 138 nanomole per liter of cortisol, this gives rise to possibility of autonomous cortisol secretion. And if it's more than 138, then this should be a adrenal Cushing's or autonomous confirmed autonomous cortisol producing adenoma. But however, they want to move away from this definition because for them, even for mild autonomous cortisol secretion, already associated with significant cardiometabolic morbidity and some reported mortality as well. So when we know that the OTST is not suppressed, we want to confirm that this is ACTH independent. So you do want to send the ACTH, and this is supposed to be suppressed. And DHEA usually will be suppressed as well because chronic suppression of your hypothalamus, pituitary, and adrenal axis will lead to low DHEA level as well. So in MAX, you do want to screen for any concomitant diabetes, hypertension, vertebral fracture. And if you want to decide whether or not to send this patient for surgery, you have to establish within an expert multidisciplinary group, and you have to take into account the patient's age, their general health, the degree and persistence of non-suppressible cortisol after dexamethasone, the severity of the comorbidities that is in existence, and the patient's preference as well. And this is the meta-analysis done in this study. And this is the forest plot basically show that the prevalence of diabetes, hypertension, and dyslipidemia in MATS are about 15 to 40% higher. And if they have a significant, so basically this is a study that was just published in 2020. I think the endocrine team must have heard of this study, whereby this urine X study was actually, the primary objective was to see the utilization of urine steroid profile, or what they call as urine steroid metabolomics, in terms of helping and aiding to diagnose adrenal cortical cell carcinoma. So actually this is one of the first prospective study in assessing adrenal incidentaloma. and they actually looked into about 2,000 patients, and about half of them were found to actually had MACs. So they said that in their cohort also, they had higher percentage of getting hypertension, type 2 diabetes, and usually if they are hypertensive, they are more poorly controlled, whereby they require 3 or more antihypertensive, and they are at higher risk of insulin-treated type 2 diabetes. And majority of them were women and mostly of postmenopausal age. So if the patient has significant comorbidities associated with MACs, let's say worsening diabetes control, hypertension, dyslipidemia, vertebral fracture, and you decide to send the patient for operation. So basically, this meta-analysis just want to demonstrate to you, there are improvement in terms of glycometabolic control, blood pressure, and dyslipidemia following adrenalectomy in MACs. All right, so this is the summary that as I mentioned just now. Okay, back to our case, we did the functionality testing, which showed that all these STs appropriately suppressed, less than 50, aldosterone were not elevated, and 24-hour urine metanephrine were all within normal range. And this is where we actually want to decide what is the next management for her, okay, and when, in which circumstances do we actually want to consider performing an adrenal biopsy. So if you're talking about consideration of adrenal biopsy, it should not be a routine in a patient when dealing a patient with adrenal incidentaloma and mass. So if you can consider this if it will influence your management. So somehow in the, for examples, if there is a history of extra-adrenal malignancy, okay, in the setup of, let's say, if you're thinking about lymphoma, sarcoma, infiltrative or infectious process, so you do want to avoid doing a biopsy if the adrenal mass is likely to be an adrenal cortical cell carcinoma, because risk of tumor dissemination and seedling when you introduce the needle to an ACC. And it is actually very, very important before you subject a patient for any adrenal biopsy or even any procedure, you have to make sure that the adrenal mass is not hormonally active PO. Okay, and so it's very important for you to exclude FEO because you might render the patient to get a catecholaminergic crisis on table. Okay, and if the lesion has not been conclusively characterized as benign by imaging, so we do not routinely do adrenal biopsy if the mass is actually benign, and if we know that the clinical management of the patient won't be altered by the knowledge of the histology. So basically, this is the summary of the chart of what I mentioned. If you're dealing with a patient with extra-adrenal malignancy known to have some sort of any breast CA, for example, like in our case, if the CT adrenal showed benign radiological features, okay, you still see whether any relevant hormone access, and if that's yes, you do an individualized treatment. If there's no, then you manage as per for primary malignancy, meaning that you will do imaging as per protocol for that primary malignancy surveillance. Okay, if the radiological features is not benign, you have to exclude FEO. All right, and if you think that the result will actually alter the management, meaning that the pathological histological diagnosis will alter the stage of the patient and etc., then yes, there is a role for adrenal biopsy, FDG PET, or even resection. So let's say if the patient has a malignancy and the patient already has so many metastases as well, like liver mets, bone mets, lung mets. So you know that even knowing that whether the adrenal mass is metastatic will not change the management, because anyway it's already stage 4, then you do not subject this patient to adrenal biopsy. So when talking about adrenal surgery, adrenalectomy is the standard of care for unilateral adrenal tumor with clinically significant hormone excess. In patient with MET, surgery can be considered in patient with relevant comorbidities. And remember, when you send a patient with adrenal, I'm sorry for the speaker interruption. All right. So if you send a patient with adrenal Cushing's or MACs for adrenalectomy, you have to cover the patient with steroid dose, stress dosing, usually IV hydrocortisone 100 mg stat, then 50 milligram QID perioperatively if the ODST is more than 50. Because as you know, in MACs and if adrenal Cushing's, the contralateral gland of the adrenal they will remain dormant and will have no capability to secrete cortisol. So when you remove the source of this excess cortisol, and when you do adrenectomy, so the patient might go into adrenal crisis. Okay, so let's just go through this chart. Basically, when you talk about benign adrenal mass, okay, which cause any hormonal excess, yes, including MAX, they actually propose to do a minimally invasive approach. Okay, even if the unilateral adrenal mass you suspect that this is malignancy, but the diameter is still less than 6 centimeter, and there is no adjacent invasion, then you can still do a minimally invasive adrenectomy. However, if the unilateral adrenal mass with radiological finding suspicious of malignancy and there is a signs of local invasion, then you might want to do a open adrenectomy. So why actually we want to choose a laparoscopic adrenectomy and moving away from open adrenectomy? So basically this review actually reviewed 911 cases, and they already see that compared to open adrenectomy, those patients who underwent laparoscopic adrenectomy associated with low morbidity and complication rate had less blood loss and post-operative pain and shorter hospital stay. So basically the risk factor, the independent risk, when do they actually convert from laparoscopic to laparotomy open, it depends on the tumor size more than 5 centimeter and histological type, and when they are actually few. So these two are actually independent risk when they need to convert from laparoscopic to open. Okay, how do you follow up this patient? Okay, let me just bring you through this chart. Okay, so basically any size, if that is less than, basically any size, as long as it is homogeneous and has a Hounsfield unit of 10 or less, no further imaging is required. So this is actually in contrast with the 2016 Endocrine Society guideline. Basically, they use a cut-off size of 4 centimeter. But now, according to the latest guideline, irrespective of the size, as long as the Hounsfield unit is less than 10, then no further imaging is required because they find that the risk of malignancy is actually very low. So they drop the cut-off size of 4 centimeter from the latest guideline. Okay, so if you have a head shoe in between 11 to 20 and the tumor size is still less than 4 centimeter and you've done the hormonal workout, it's all within normal range. So what do they suggest? Actually, they suggest to do an immediate additional imaging to avoid any follow-up imaging. So additional imaging here, meaning it's either your enhanced CT or your MRI adrenal, depending on the availability in your center, and or alternatively, you can do a repeat imaging after 12 months. Okay, if you have something like everything is in between, okay, let's say you have a tumor size more than 4 cm with a head shoe of 11 to 20, or you have a smaller tumor less than 4 cm, but the head shoe is more than 20 or heterogeneous, so they suggest an individualized approach with discussion in MDT. And if the likelihood of malignant is still low, then we can observe. But if this is still indeterminate, then we can opt for immediate surgery as well. But if we do not send the patient for surgery, they suggest an interval imaging after 6 to 12 months, either with non-contrast CT or MRI. Sorry, my slide is not moving. Okay, if the adrenal mass is more than 4 centimeter, is heterogeneous, and head shoe is more than 20, so we do know that this has a relevant risk of it being malignant. So they suggest to discuss this case in MDT, and most likely the patient will need an immediate surgery. So together with this, they suggest to do a complete staging for the patient, and you might want to do a CT thorax or FDG PET to complement your existing CT. And if you do not perform any surgery, yes, you need to repeat another imaging after 6 to 12 months. So during your follow-up imaging, what do you usually see and what is actually significant? So basically, if the maximum diameter increase more than 20% in size, it additionally with at least 5 mm increase in the maximum diameter, then they suggest surgical resection. So guideline to guideline, it actually differs. If you see Korean guideline, they actually take about 1 centimeter cut off, increase in the maximum diameter for it to be significant. So this guideline also say that we do not need to repeat any hormonal workout in patient when the first line, when we actually already ordered the first time around is already within normal range, unless if you see new clinical signs of endocrine activity appears and there is worsening of comorbidities of hypertension and type 2 diabetes mellitus. Because here they actually say that in max, the risk for it to go into overt Cushing's is actually very low, and some study reported it to be about 0.2 to 0.6% risk. In a patient with MATS, who do not go adenectomy, so they recommend to do annual assessment of comorbidities that may be potentially attributable to high cortisol, such as diabetes screening, hypertension, dyslipidemia, and according to them, this may be done in the primary care setup. So a separate discussion, what they highlighted in this guideline was actually adrenal incidentalomas in young patients, because as I mentioned just now, if they are less than 20 years old, usually the prevalence is very, very low, less than 1%. So if you have any incidentaloma in young patients, you have to think whether this is a clinically significant hormone excess or malignancy. So if you're talking about children or adolescent pregnant women, we prefer doing MRI because there is no ionizing radiation, and you will not expose the patient to so much radiation rather than CT. So and they have a higher threshold to advocate surgical resection if you find an adrenal mass of indeterminate origin in an adult less than 40 years old. Okay, in conclusion, 90% of adrenal tumors are benign and 70% of them are non-functioning. All adrenal incidentaloma will need hormonal workout, and we have to exclude few if the HU is more than 10 on unenhanced imaging. And if they have hypertension and hypokalemia, you want to exclude primary hyperaldosteronism. And imaging phenotype is always the key. Always look at the Hounsfield unit. And if you do an enhanced CT, look at the absolute washout, look at the relative washout. You want to look at the tumor margin. You want to look at whether they are homogeneous, inhomogeneous. And this imaging phenotype, why is it important? Because it even overrules biochemical workout. Thank you, and I'm happy to take any questions.
Thank you, Dr. Sana, for the comprehensive presentation. Now, I'd like to invite the audience. I can see about 170 people are online now. So please, but I couldn't see anything being typed in the chat box. We'll give you some time to type any questions. So meanwhile, maybe I can get things kickstart with regards to the questions. Well, Dr. Sana, you mentioned about the hormonal workup. In general, we usually tend to do the overnight 1 milligram dexamethasone suppression test. Now, in a situation whereby patients are on medications that we definitely know affects the dexamethasone and the patient could not be withdrawn with that kind of medication, what would be the other alternative that you would suggest in terms of doing the hormonal workup?
So basically, they did mention about repeating the overnight dexamethasone suppression test or do a 24-hour urine cortisol. But at the same time, they mentioned that if you are dealing with MAX, most likely your 24-hour urine cortisol will still be within normal range. So some actually mentioned about 8 milligram overnight dexamethasone suppression test, because their principle, if you do the 1 milligram, and if the patient is on some medication that cause fast, if they are the fast metabolizers, or if they have a poor absorption. So if by their principle, if they give the 8 milligram at higher dose, so they might get a more accurate result if they sample the morning cortisol the next morning. But I think this has not been validated or introduced as a general recommendation yet, Prof. So I think depend on the different recommendation as well. Yeah.
Okay, just to add on that, I think with regards to the if your patient could not, whereby you cannot subject the patient for overnight dexamethasone suppression test, another alternative you can consider the urinary free cortisol, like Dr. Sana mentioned. But if you do the urinary free cortisol, the sensitivity and specificity is about only 70 up till 70%. But there are studies that show maybe if you use the mass spectrometer, measuring the urinary free cortisol with a mass spectrometer, then it will give you a higher sensitivity and specificity. So that is just one of the possible alternative if you really cannot subject your patient to an overnight dexamethasone suppression test. Okay, I think I can see one question. Do all patients with hypertension and hypokalemia need to rule out primary hyperaldosteronism?
Yes, Prof. If we have an adrenal mass, but the patient does not have hypertension, so they mentioned that we do not necessarily need to do a aldosterone ratio. But if they have adrenal mass with hypertension, with or without hypokalemia, remember, because not all primary hyperaldosteronism will have hypokalemia. I think about 30%, Prof, will have hypertension with hypokalemia in primary hyperaldosteronism. So if they are hypertensive with adrenal mass, please do a aldosterone ratio irrespective whether they are hypokalemic or not.
Yeah. So just to emphasize, because the question was saying about patients with hypertension and hypokalemia. If you do have patients with hypertension and hypokalemia, do screen for primary aldosteronism. Okay, the second question is from Omar Shukri. The question is, from primary care perspective, when we suspect primary hyperaldosteronism, which means hypertension and hypokalemia, it's kind of difficult to withdraw the medications, for example, the ACE inhibitors or the ARBs, which can affect the results of ARR. So do we need to refer this kind of patient to the endocrine centers? Okay, that's the question.
Okay. All right. So, so I think this is your primary hyperaldosteronism question. I think if you can try to still switch to the non-interfering medication like verapamil, prazosin. I think this is still available in primary care case setup, Prof. So, but let's say if you think that if you do a medication switching to the non-interfering antihypertensive, and this will be at risk to the patient. Let's say you know that this patient has a very refractory hypertension, who has a very severe comorbidities, a history of like hypertensive bleed before due to high BP, and you think that you are a bit more cautious in terms of switching the patient who are already stable on current antihypertensive. So I think look at the antihypertensive that the patient is on. Let's say if the patient on pyrindoprid and like ACE inhibitor or ARB, you have to know the principle, what are specific antihypertensive will do to your ARR. So let's say for ACE inhibitor or ARB, you know that for ARR, they will kind of like make the ARR aldosterone level normal or elevate or lower, and it can bring up the renin, so it can cause false negative aldosterone ratio. But if you send ARR and the patient is still on ACE inhibitor and ARB, you interpret it in context of knowing what is this medication will do to your ARR, then you might still be able to interpret. So you know that if this one usually cause false negative ARR, but if you have a very elevated aldosterone and you know that this patient is on ACE inhibitor and ARB, then most likely yes, this patient still has primary hyperaldosteronism. So in selected cases, when we know what the antihypertensive will do to the ARR, then we can still interpret it in context, but try to avoid spironolactone or diuretics, but other ACE inhibitor, ARB or beta blocker, you might still be able to interpret it.
Okay. If I can just summarize what Dr. Sana's long answers for the person who asked the question. So if you do have patients whereby very difficult to control hypertension on multiple agents, it's very difficult to switch them. Ideally, you try to switch. If you can't, you can still do the ARR with that medications on board. It's just that you need to interpret the results with the medications on board, whether that medications causes suppressed renin or suppressed aldo, so interpret in that manner. Because we do have patients on multiple, I've got patients on 7 antihypertensive, but difficult, cannot switch them because even with 7, they are still poorly controlled. Then you just do the ARR, but interpret in that setting, okay? If you do have patients who are on spironolactone, for example, I'm sure some of you have patients on spironolactone. So if their renin is still suppressed, you can interpret, you can do the ARR without switching the spironolactone. Okay. Okay, I've got another question. This is from Yanni. Yanni is asking, do we do 24-hour urine metanephrine for all patients with indeterminate adrenal incidentaloma with plain HU that is more than 10, irrespective of the size?
Yes, Yanni. So basically the latest ESE guidelines say as well, mention as well. So as long as the HU is more than 10, you have to send a 24-hour urine metanephrine. So basically, they say that that's why they say that the imaging phenotype is more important than the biochemical. Basically, because sometimes you can still have a mass which is less than 4 centimeter, but very heterogeneous, H2 more than 20, with poor washouts, which can still be FEO, although they are not for more than 4 centimeter in size. And there is also an entity, what they call a biochemical FEO, whereby, it's a small FEO, but they do a 24-hour metanephrine, it's negative, but when they look back at the HPE came back as pheochromocytoma. So of course, usually FEO, we say that it's usually more than 4 centimeter, but there are some cases whereby the sizes are actually less than 4 centimeter.
Okay, so which means if it's a Hounsfield unit more than 10, proceed by doing the metanephrines or the plasma or the urinary metanephrines. Okay, any other questions? So far I've not seen any questions yet. So meanwhile, just to allow the rest to ask questions, if I can proceed with the next, Dr. Sana. So what would be the natural progression of an adrenal incidentalloma? Let's say you've done the workup, they are hormonally inactive, they are benign. So what would be the natural history of that kind of tumor?
So usually if to begin with, the HU is less than 10, Prof, and then we deduce that this is lipid rich, more than 60% from absolute washout and more than 40% from relative washout. Usually the cause is actually they will not go into like malignant transformation, very rarely. And that's why in this guideline, they confidently say that we can actually straight away discharge the patient without doing any further imaging. But if we look at US guideline, even when it is benign feature, they will still actually follow up the patient with some sort of annual imaging up until 4 years, if I'm not mistaken. Similarly with Korea guideline as well for adrenal incidentalloma, they will follow up the patient even when the first CT say that this is actually showing benign features.
Okay, any question? I can see Dr. T, whether I'm not sure whether Dr. T wants to ask questions, whether she wants to unmute and ask questions directly, or any one of you would like to ask further questions to Dr. Sana? Well, with regards to the natural progression, just to add on what Dr. Sana has mentioned, there is a meta-analysis looking at the natural progression of adrenal incidentalloma. So in general, if they are benign, in that meta-analysis, it has been shown that the tumor grew only about 2 millimeter in about 50 months of follow-up. So because some of you might be wondering if you are seeing that kind of tumor, which is benign, you would then wonder what is the rate of growth of that kind of benign nodule. So meta-analysis have shown that kind of rate of progression. Okay. Any other questions from the rest? I've not seen any other questions. Just to use up the time, Sana, so that it will benefit all our audience. With regards to the malautonomous cortisol secretion, why do we continue? Why do we need to sort of do a hormonal workup every year? Why is it important?
Actually, from the latest Endocrine Society guideline, ESE guideline, basically say that once we establish that this is max, Prof, they do not advocate for us to do an annual ODST for this patient, because according to them, the risk of a max transforming into an overt adrenal Cushing's is actually very, very low, only about 0.6%. So this is actually in contrast to Korea Society guideline, basically because they actually do a ODST in max every year, because in the sense that they want to make sure that they are not dealing with like overt Cushing. So but along the way, when we do monitor the patient annually for cardiometabolic risk factors, let's say diabetes, hypertension, dyslipidemia, and we happen to encounter that, there is a worsening hypertension control, diabetes control, and there's new fracture. So we might want to reassess back the ODST when this happens, when we do the annual cardiometabolic screening for this patient.
Yeah, I think it's important for malautonomous cortisol secretion is to evaluate their cardiometabolic comorbidities or risk, because it has been shown that this cardiometabolic risk, for example, hypertension, diabetes, obesity, cardiovascular events, they are much more higher in patients with mild autonomous cortisol secretion. So that's the reason why you do need to assess or evaluate these comorbidities every year or along the way of these patients. And for your information, mild autonomous cortisol secretion, they do not, very minimal, majority of them do not regress back to normal. So they can progress with the other cardiometabolic comorbidities. So you do need to assess and treat their cardiometabolic comorbidities. Okay, there's one question, Sana. This is from anonymous attendee. Adrenal incidentaloma in pregnancy. Which imaging is safer and give better information with regards to adrenal mass?
So basically, if you talk about pregnancy, usually the guideline actually mention MRI adrenal prof. So 1.5 Tesla is adequate for MRI. So I think if you go to adrenal center, they will do more adrenal MRI compared to our own center. Okay, because of the availability. So why we want to do a adrenal MRI in pregnancy is because we do not want to expose the fetus to the ionizing radiation of doing a CT scan. So if you do MRI as well, so what we want to see is actually the in-phase and out-phase sequence of the MRI adrenal. And if this is lipid rich, then you will see a signal drop when you go into from the in-phase to out-of-phase, whereby you will see a hypo-intensity area. Okay, but usually, as I mentioned just now, why we discuss this separately, even in the guideline, basically they say anyone who is less than 40 years old and you find an adrenal incidentaloma, you really have to look for whether this is a whether this is a hormone secreting or malignancy related, because usually they do not have an adrenal incidentaloma when they are pregnant because they are young, right? Yeah.
Okay, so to cut short, meaning if in pregnancy, you just do MRI. Okay,
Yes.
That's the mode of imaging modality that is safer in pregnancy. Okay, Sana, there's another one. Thank you for the insightful session. I would like to ask, can we do ARR and overnight dexamethasone suppression test in the same setting?
Okay. So basically, if you do dexamethasone the night before that and you sample the aldosterone the next day, it will affect your aldosterone level. So basically, usually I will tell the patient to do in a different setting, whereby I will do a overnight dexamethasone suppression test on the different days. So you try not to sample on the same day, okay? Because that will affect your aldosterone and it might cause a false result. If I'm not mistaken, falsely low profile. If I'm not mistaken.
So yeah, so do not do in the same setting, because it will affect the aldosterone. So if you want to do overnight DEXA and ARR, do on a separate days. Okay. Another question is, I think from the same person who asked about the pregnancy just now, how to interpret the hormonal testing during pregnancy? I'm not sure what kind of hormonal testing, but maybe you can summarize, Anna.
Okay, so basically, in general, we do know that in pregnancy, they have a high level of estrogen, and this might affect the cortisol binding globulin and might affect the cortisol interpretation as well. And if in pregnancy, we expect the cortisol level usually higher than normal, but there is no population-based reference range for cortisol level in pregnancy. So I think depends of the clinical setup, your clinical presentation, and which hormonal functionality testing do you want to send for? Because usually, if let's say this is a normal young hypertension and you refer to us, we do not send for 24-hour unimetanephrine, cortisol, ARR in pregnancy, because you know that during this pregnancy it can affect the result. But let's say if we need to, let's say the symptomatology is very suggestive, let's say this is very florid, depending on the clinical symptomology, specific clinical symptomology, then you might still want to do the specific functionality testing in this pregnant and interpret it in caution, whereby you know that how pregnancy will actually affect the hormonal testing. So not sure which functionality testing that you mean.
Is there any other questions from the audience? Okay, there's another one coming up. A non-functioning adrenal incidentaloma that is less than 4 centimeter. Is it safe to discharge them from follow-up if a repeat CT 1 year later is the same or no change?
Okay, you mean the HU is less than 10? Yeah. Assuming the HU is less than 10?
Scenario, one less than 10 and one is above 10?
Okay, so if the HU is less than 10, irrespective of the size, we can discharge the patient. We do not need to do a follow-up imaging. Okay, and if let's say depending on how high is the HU, if you see the HU is about 10 to 20, they mentioned just now, so you want to do the repeat CT adrenal, it depends on the enlargement of the size. So if there is more than 20% increment in the maximum diameter, or more than 5 mm increment in the maximum diameter, then you say that, okay, there is a progression, then you might want to further investigate and further discuss this in the multidisciplinary group. But if there's no progression and it's non-functioning, then I guess we can discharge the patient. But I think it depends on how high is the HU level when you repeat the CT. If you're talking about very high HU level, let's say more than 20, then of course you don't want to discharge this patient, because that would say that this is still indeterminate. Then you go back to your flow chart just now, how you deal with that HU and that size, and when is the next imaging.
Yes, I think from the recent guideline, if you notice the change of the ESE, European Society Endocrinology, to 2023 versus 2016, the size of that 4 centimeter has been thrown out. Okay, so now they've looked at the Hounsfield unit that is more important. So if the Hounsfield unit is less than 10, and if like in this question is saying that the adrenal incidentaloma is less than 4 cm, then if let's say you repeat 1 year later, it is still the same, then ESE actually suggested you do not need to do further hormonal workup or CT imaging. But again, like I said, guideline is a guideline, so you have to take your patients at individual approach. So in general, that's the approach for general patients. Okay. Any other questions? Yes.
Multiple nodule bilaterally. That's a new question. I think bilateral multiple nodule.
Okay. So if the adrenal CT shows multiple nodule bilaterally and hormonal profile just showed mild autonomous cortisol secretion, how would you manage? Is it the same? This is from Libing, yes.
Yes, Phoebe, so basically, how you go about the management of bilateral meds is still following your unilateral meds as well. You have to look into whether there's any significant comorbidities, related comorbidities, any progression or worsening of the comorbidities related to the excess cortisol, and what are the patient age, the sex, the degree of non-suppressible cortisol level, and what are the patient's preference. So of course, because it's not that easy to subject the patient for bilateral adrenectomy, because you will render the patient to be permanently hypocort and mineralocorticoid deficient state. So this kind of patient, they are at higher risk to go into hypoadrenal crisis. There are some article that I read along the way that they mentioned that you might want to consider, if you're talking about bilateral overt adrenal Cushing's, you might want to consider removing the bigger nodule on the unilateral side. So I'm not sure about that as well. But usually, if that is when we talk about bilateral Cushing, but when we talk about bilateral max, then you still deal with the unilateral max as well. You have to see the whole thing.
Yeah, but yeah, in general, if it's the hormonal is the same as mild autonomous cortisol secretion, and the bilateral multiple nodule is benign, then you follow almost the same step as what Dr. Sana has presented. Okay, any other questions? Okay, sorry, is there anyone?
There are no questions, Prof.
Okay, so I think
I think that's one.
cannot hear you. Can't hear you very well, Dr. Vidya.
I think that's one last question.
There are 3 more new questions. Are you able to view it once at the webinar chat and once under the Q&A?
Okay, just hold on. Because the participants are sending at both the chat box as well as the Q&A. Okay, there's another one question. Whenever we encounter patient with resistant hypertension, drug compliance in patient, in addition to ultrasound renal Doppler, do we need to test for ARR, plasma metanephrine, and 24-hour urinary free cortisol? Or can we just go clinical first and choose either of the tests? This is from Omar Shukriya. You can get the question, Sana?
Yes, Prof. So basically, bearing in mind, not all methanephrine's will have the classical paroxysms of headache, flushing, and palpitation. And if you ask most of the PHIOs also, they might not have the classical triad of symptoms. So if you want to go pure by clinical, and then another thing for ARR, as I mentioned, only 30% of them will have hypokalemia. So if talking about a young patient with refractory hypertension, young hypertension patient, then you might want to do this concurrently. I mean, so like in a sense, why do we decide with ultrasound renal Doppler first compared to, you know, your hormonal workup for your hypertension, like your ARR, methanephrine, and 24-hour uric cortisol? But of course, you want to go by clinical symptoms, but I think it's not wrong for you to test this together. And if you look at the indication to send your ARR, so there's I think this is one of the indication already to send your ARR according to our primary hyperaldo guideline.
Okay, there's another one more, Sana. We are running out short of time. If adrenal lesion in background of extra-adrenal malignancy or lymphoma, do we still need to do the 24-hour urinary methanephrine before the biopsy?
Yes. If usually if you're dealing with lymphoma, usually the lesion is indeterminate. So if any patient that you want to do, if as I mentioned just now, more than 10 HU, because seldom you have a lymphoma that, you know, like lipid rich less than 10 HU. So especially if you want to subject the patient for adrenal biopsy, you do want to rule out whether this is PHIO or not before any procedure, respectively. Yeah.
Okay, I think we'll go to the last question. How to do hormonal workup in patient with CKD and adrenal incidentaloma?
CKD and adrenal incidentaloma. So good question. So basically, I think depending on what is the stage of CKD as well, because we know that if you think about doing 24-hour urine cortisol, 24-hour urine methanephrine, and this patient already have an advanced CKD, then that might affect your results. So depending on this, you might want to, you know, switch to whether you want to do a plasma methanephrine, and then whether you want to do like other forms of testing for Cushing, like your overnight Dextro or even your midnight salivary cortisol. So I think you have to see what is the stage of CKD, what is the urine output, what is the EGFR, the creatinine clearance for the patient in CKD.
Okay, so in general, if I can just add of what Dr. Sana has mentioned. So if you have a patient with CKD, it depends on the degree of the CKD stages. Based on our experience with primary aldosteronism and CKD, if their CKD is up till stage 3, we find that their ARR is not much being affected. But once their CKD is stage 4 and above, which means advanced CKD, then the ARR may be affected, because at present we do not have ARR cutoff in CKD population. Okay, so we base the cutoff mainly on the general population. Okay, but we know that advanced CKD is associated with renal renin being reduced, therefore it can result in a false positive result. With regards to PHIO, if you have advanced CKD, then it will be advisable to do plasma methanephrine rather than the urinary form of investigation. Okay, so I think with that, I think we can conclude this session. I think we have Dr. Sana has presented very comprehensively, and we have got a lot of questions, very interesting questions from all our audience. I think you all must have, I'm sure you all have benefited from this session. I thank you, Dr. Sana, for a great presentation, and I give back to Dr. Vidya.
Okay, thank you very much, Prof. Dr. Norlela and Dr. Sana, for that very insightful and informative session. And thank you to the participants as well for being very interactive. So thank you, everyone. And please join us next week, next Thursday at 3 p.m. for a session on obesity. Take care and have a good evening.
Thank you.
Thank you. Thank you, Prof. Thank you,
Bye.
Bye, everyone.